So I think the program has been contested for a while, and that providers that are in 340B, they want to be able to optimize the benefit that they get from 340B, and then manufacturers, I think, have concerns about the size of the program, how providers are using the 340B benefit. But what I think is different about this moment, and this has been a trend that has been emerging for many years, is
Greg, we were just discussing about all the litigations and court decisions that are coming around. So we have seen an increase that major 340B policy questions are being resolved in court rather than through regulation. What does that shift mean for how stable or predictable this program is?
I really think that it's going to require sort of a wide range of departments at a typical covered entity to make something like this work. You're going to need your individuals that are responsible for, 340B operations, making sure that sort of all the systems and processes are in place.
And Greg, what are your views about AI? It seems like there are a lot of complexities in this program. Do you think AI can help us to streamline this process at any stage and make it easier, especially for the providers and covered entities? Welcome to 340B Pulse, a NorthArc Health podcast powered by Purologix. I'm Mohammad Atif, your host. I'm CTO and founder of Purologix and NorthArc Health. On this podcast, we talk with healthcare leaders, operators, innovators, and builders about the real system behind care delivery. Not just a strategy on paper, but what actually works in practice. And today we are diving into a topic that is becoming increasingly urgent across care organization, home care, and aging services. It's about duplicate discount, rebate model, and legal uncertainty in 340B's next phase. So we shall be covering the duplicate discount problem, why the shift rebate-based model has become such a flashpoint, what the legal battles of the last year actually tell us about the limits of regulatory action, and where this program is realistically headed. And to help us navigate all of this, we are joined today by Mr. Greg. Greg is an attorney and longtime 340B policy and compliance leader whose work has focused heavily on the legal, operational, and regulatory side of the program. Over the course of his career, he's worked closely on the issues involving 340B compliance, health policy, government affairs, and the evolving relationship between manufacturer, covered entities, and regulators. He brings a unique perspective that combines legal analysis with real-world operational insights, especially at a time when questions around duplicate discounts, rebate models, contract pharmacy oversight, and data transparency are reshaping how the program functions in practice. Greg, welcome to 340B Pulse. It's really great to have you here.
Thank you, Mohammed. I'm really happy to be here with you and your audience.
Thank you. So, Greg, before we begin, it would be great to hear a bit about your path into this space, your journey overall.
Yes. So I started out going to law school and began my career in DC. And originally, I was not in the 340B or the pharmaceutical space. I worked for a couple of trade associations that worked in the health IT sector. And like a lot of, young new professionals, I was looking for my next opportunity. And I saw what looked like an exciting position with the organization 340B Health. They actually were known as safety net hospitals for pharmaceutical access back then. For your members of your audience too, maybe you're not familiar with the organization, they are the association that represents hospitals and health systems in the 340B space. And I think they now represent up to 1,600 hospitals and health systems. And I ended up being there for about a decade and a half, doing a lot of the kinds of work that you mentioned, Mohammed, working on compliance issues, doing a lot of education of our members, not just on compliance issues, but regulatory and legislative developments in the 340B program, also doing a lot of advocacy on behalf of our member hospitals and health systems. So, everything from meeting with members of Congress on occasion to submitting comments on proposed regulations and guidance. After working at 340B Health for an extended period, I then worked for Walgreens on health policy. And while my portfolio was larger than just 340B, a lot of my time was spent on pharmaceutical pricing and 340B in particular. And then at the beginning of this year, I moved to the law firm Powers, Piles, Sutter, and Verville. It's a law firm based in Washington, D.C., and they have a large practice of professionals that spend the majority of their time focused on 340B. And I do a lot of work, particularly with hospitals, but also grantees on 340B compliance and regulatory issues, but then also still doing some advocacy on behalf of covered entities in the 340B program.
Awesome, Greg. So it seems like you have been through all these different roles, and you are well deep into the 340B. So from where you are coming, how would you describe at this moment in the program's history? Is this most contested it has ever been, or have we been here before?
So I think the program has been contested for a while, and that providers that are in 340B, they want to be able to optimize the benefit that they get from 340B. And then manufacturers, I think, have concerns about the size of the program, how providers are using the 340B benefit. But what I think is different about this moment, and this has been a trend that has been emerging for many years, is I don't think the program has been as complex as it is at this particular moment. And there's so many different issues and so many different places where that complexity is happening. I'm sure we'll probably talk a little more about this, but you have so many court cases involving 340B that stakeholders have to follow. You have pharmaceutical manufacturers coming up with their own policies for different aspects of 340B. So that makes the environment more complex. And then as we'll dive into a little bit deeper, you have HRSA looking to perhaps change the 340B program for at least some drugs from an upfront discount to a post-purchase rebate, which would be a very significant change. So I would say it's been contested for a while, but it's just the number of complexities because of all of those different areas of disagreement have just made the program so much more complex than it was even 5-10 years ago, but certainly compared to 15 years ago when I started in the 340B space.
Got it. That context really matters, and because the nature of this particular tension feels different. It's not, Greg, just about the policy disagreements. It's about the program's foundational structure. So let's get into the core of it. For the listeners who may not live in this world every day, what is a duplicate discount problem in a particular term, and why has it become so difficult to solve?
Yes. So a duplicate discount, broadly speaking, is if a manufacturer were to provide both a 340B discount and a rebate on the same claim. The most common kind of duplicate discount, the kind that people are most familiar with, is what's known as a Medicaid duplicate discount. So this is where a manufacturer provides a 340B discount to a covered entity, but then they would also provide a Medicaid rebate on that same drug to a state Medicaid agency. And that's not a new concept. Since the 340B program was created, there have been mechanisms in place to protect manufacturers from paying duplicate discount, Medicaid duplicate discount on the same claim for fee-for-service. But as the Medicaid drug rebate program was expanded to Medicaid managed care beginning in 2010, And then there have also been other federal legal developments that have created new kinds of duplicate discounts. The environment has become significantly more complex. When we look at fee-for-service duplicate discounts, it's relatively straightforward. The federal government created a database that allows 340B providers to say, for this billing number, I'm going to use 340B drugs or I'm not going to use 340B drugs. And then a state Medicaid agency can go to that database. It's called the Medicaid exclusion file and see if a billing number is in there. And if the billing number is in there for that particular provider, the state doesn't request Medicaid rebates. But we move over to managed care and we don't have anything like the Medicaid exclusion file. In fact, HRSA, the agency that oversees 340B, in case someone's not familiar, HRSA stands for Health Resources and Services Administration. They don't have any sort of clear guidance that they've put out for prevention of duplicate discounts when it comes to Medicaid managed care. What we do have is there is a regulation that the Centers for Medicare and Medicaid Services came out with that said that states have to take steps to prevent Medicaid managed care duplicate discounts, but it's really up to the states to decide how to do that. And then through their agreements with managed care plans, they tell the managed care plans that they need to have mechanisms in place to make sure 340B claims are excluded. And so you have not just each state kind of maybe doing their own different thing, but you also maybe have differences between Medicaid managed care plans in the same state. And I think it's not always clear to 340B providers even what the requirements are if there's not sort of an easy go-to place for a provider, maybe on the state Medicaid agency website to sort of see what is required, or they may not necessarily know exactly what the policy is of a particular Medicaid managed care plan. So you go from the fee-for-service side, where you have one federal system for preventing Medicaid duplicate discounts, to the managed care side, where, again, it varies by state, it can vary by managed care plan, and it's not always clear what is required.
Got it. But from drug manufacturer, they are increasingly argue that rebate-based model are necessary to prevent duplicate discount. What is the strongest version of their argument, and where do you think it holds or breaks down?
I think that manufacturers have been frustrated for a long time about the lack of claim level data that they get. I know that even before this conversation about moving 340B to a rebate program came up, I have had conversations with manufacturers where they don't like that they don't get claim level data from state Medicaid agencies when state Medicaid agencies are requesting Medicaid rebates. They feel like they don't have the data that they need to really validate claims and make sure they're not paying duplicate discounts. And so they really need covered entities to identify 340B claims. Otherwise, there isn't going to be any definitive way for them to know if a claim is 340B, if a covered entity used 340B for a particular claim. Also, I don't necessarily know how much of this has been, validated by a third party, like the federal government, but many manufacturers do claim that they are paying, millions or hundreds of millions in duplicate discounts. So I think those are probably the most compelling arguments: the need for the data and the fact that without that data, they're very concerned that they're paying a lot of duplicate discounts that are, eating into their finances.
Got it. And Greg, as you know, back in last year, HRSA attempted a rebate-based pilot, which was later blocked before implementation. What does that episode tell us about the limits of regulatory action in 340B right now?
Well, I think that it tells us a couple of different things. I think that HRSA has to really kind of make sure that they're using the appropriate process if they are going to put a rebate program in place. The reason that the rebate program that was going to be a pilot didn't go into effect to the beginning of this year was that it was legally challenged by providers, and the court ultimately found that the federal government didn't provide a good, reasonable basis for changing its longstanding policy of 340B discounts being an upfront price. And then they also found that HRSA did not properly consider the impact of a rebate model on providers. And so I think that this time they're being kind of much more, I think, deliberative. I think they're taking more time. There was just a couple of opportunities for stakeholders to provide comments on a potential new rebate model. So I think that the government is a little bit limited in what they can do just based on the rules that govern sort of how they can come up with new policy. And I think it remains to be seen whether, if they do end up doing another rebate model, will that also withstand legal challenge. I think it also shows the limits of regulatory action, because I think while manufacturers would very much welcome a rebate program, providers are extremely concerned about a rebate program and sort of what that impact would be on them and their patients. And so, it's not like legislation where you potentially could do sort of a reset of the program and maybe do it very differently. There's sort of limits to what HRSA can do. And sometimes when it does things within those limits, maybe it makes one group happy, but doesn't make another group happy.
Got it. And I think it comes back to your first conversation point. You were talking about manufacturer wanted to have transparency, and they wanted to have access to claim level data, and they wanted to make sure that this program is being used for the right purposes. But at the same time, covered entities, I think they are feeling a lot of overwhelmed with all the extra clerical work that they have to do, and records keeping and audits and everything. So they are feeling a bit overwhelmed. They are being questioned, and then the financial limitation that they have to pay upfront, and then they will get the discount later on after the claim is approved, right?
Yes. Yeah. Providers that I have spoken with have expressed a lot of concern about a rebate model, especially if it ends up going from, a test pilot that just involves a handful of drugs to becoming the way the entire program operates. You already, hit upon the concerns. There's concerns about cash flow because they're going to have to pay more upfront for these drugs and then wait for their rebates. And a lot of providers I've spoken with say they just, don't necessarily really sort of have the amount of cash on hand that makes that kind of discount program viable. They've also expressed concerns about, the burden of the program, not just sort of getting their system sort of up and running, but also sort of managing that on an ongoing basis and making sure that they're getting their 340B rebates they would be when they do, and that they don't when they shouldn't. And then sort of all the work that it may take working with individual manufacturers. If they feel like maybe they were owed a 340B rebate and they didn't get it, or they got a 340B rebate and they don't think they should have. And then I think probably I would say not probably, I know their biggest concern is that both the financial cost and the administrative burden, really could eat into their ability to, sort of provide the level of services that they provide for their patients today, because it's not like they necessarily have a pot of money that they can just move over to managing a rebate program. So they may have to make some hard decisions about, where do they move financial resources from in order to be able to manage a rebate program.
Got it, Greg. And Greg, based on your insights or based on your experience, when a rebate model or new compliance requirements come into play, what does that actually look like inside the health system? Who has to respond, and what kind of operational burden does it create?
I really think that it's going to require sort of a wide range of departments at
Mm-hmm.
a typical covered entity to make something like this work. You're going to need your individuals that are responsible for, 340B operations, making sure that sort of all the systems and processes are in place. Not just for compliance, which obviously is very important, but just to make sure everything is operating smoothly. You're going to need help from your IT department, or you might need to outsource that to make sure that if you're doing any data submission yourself, that data submission is going through, or you may have to coordinate with your third-party administrator or your split billing vendor to make sure, again, that the data flow is going well. You're going to have to, I think, work with your finance team to really sort of figure out sort of what is the financial impact of this and how it's going to work. You'll obviously need to educate your leadership because this is going to have a real impact. I think a lot of organizations have already done, many of these things. And then you may have to also work with your HR department if you're creating new positions. So again, it's really an all hands on deck situation because it is just such a fundamental shift from how the program has operated. And I think a lot of the infrastructure in place today, it's not like you can just flip a switch and, just convert your program to a rebate program.
And I totally agree 100% on that. So let's talk about like Medicaid managed care versus the structural complexity. So what is about this Medicaid managed care specifically, like compared to our traditional fee-for-service Medicaid that makes this like 340B tracking and duplicate discount prevention so much harder?
Yes. Well, kind of following up on what I was talking about earlier, I think that the biggest difference between fee for service and Medicaid managed care is that fee for service, you do have a single federal government mechanism, the Medicaid exclusion file, that is used to prevent Medicaid fee for service duplicate discounts. It doesn't mean that states might not have their own additional requirements for preventing duplicate discounts, but there is a federal mechanism in place. But on the Medicaid managed care side, there is no mechanism. And so each state and sometimes each Medicaid managed care plan might be doing their own thing. And there's a wide variety of ways that they try to prevent Medicaid managed care duplicate discounts. Even though the Medicaid exclusion file was not set up for prevention of Medicaid managed care duplicate discounts, there are some states that tell covered entities that if you decide to either use 340B drugs or not use 340B drugs for Medicaid fee-for-service, that they're going to assume that you are doing the same thing for Medicaid managed care. Some states have established requirements to add modifiers to 340B claims, and that is possible in some instances for 340B providers, but applying 340B claims at the time a claim is billed is not feasible in many situations for covered entities because of the way they manage their 340B inventory and their determinations about if a patient is eligible. That is all done on sort of the back end. It's a retrospective process. And so they don't know if the claim is 340B until after the fact. So they either have to figure out some way to make that claim modifier work, or they might decide it is, too much to manage, and they decide not to use 340B for Medicaid managed care. So again, you just have such a wide variety of requirements. It is just challenging to manage.
Got it. And Greg, we were just discussing about like all the like litigations and court decisions that are coming around. So we have seen an increase that major 340B policy questions are being resolved in court rather than through regulation. What does that shift mean for how stable or predictable this program is?
So I think that the complexity does make it more challenging to kind of
Mhm.
understand where the program is at and where it is headed. And I think that does affect what manufacturers and covered entities sort of, you know, do on a daily basis and how they plan for the future. It's hard to plan too far out when you don't know what that future looks like because you have so many core cases that could fundamentally reshape the program depending on sort of what those court decisions are. I think that it's also just a lot again, a lot to track for stakeholders. I think also too, because so many of these different important 340B issues are in the court system, I think that does make some federal policymakers, including Congress, a little bit hesitant to make any major legislative changes because I think they want to see sort of where these issues end up. And I think the last thing I would note is that the court system is not fast. Some of these issues may take many more months or even years before we have a clear sense of where we end up on some of these different issues. And by then, we may have new issues that are tied up in the court system, which would just sort of add, further uncertainty and making it more challenging for stakeholders to manage 340B and to plan for the future.
Got it. And with the current given situation, we know that rebate program is on pause right now. Do you think HRSA and federal is working together with the manufacturer and other entities to resume this, or is it like paused forever for now?
I think, yes, HRSA is actively, I think, working towards a potential new rebate model. It is interesting in that when they asked stakeholders for comments earlier this year, the agency did not say they were definitely going to do a rebate program. So while I think there is still a very good chance because they got very close before with the first program, it's not 100% certain that they are going to move forward with a rebate program. I think that they also are trying to be very intentional and deliberative about considering all of the different comments that they got from different stakeholders, because I think they want to be able to make a case if they do a new rebate program that they were very thorough and how they went about creating that program. And it doesn't mean that someone such as covered entities aren't going to sue them to try to stop a new rebate program. But I think that HRSA wants to try to make whatever new rebate program they come up with more defensible. I think the big question that stakeholders have now is if they do a rebate program, how soon might that happen? On the one hand, I think HRSA does want to come up with a rebate program. I know manufacturers certainly want a rebate program, and I'm sure they're telling HRSA that and maybe other federal policymakers as well. But I think we could still be many months away from a rebate program. If I had to guess, I think it's going to be probably most likely no earlier than the fourth quarter of this year. And I wouldn't be surprised if we didn't get a new rebate program until the beginning of next year.
Got it. And Greg, like in this whole context, do you think HRSA is limited more by legal authority, or they have a political constraints, or is it more about operational capacity when it comes to setting clear rules?
HRSA has made the case that they are limited by regulatory authority. And for many years, they asked Congress to give them more rulemaking authority so that they could come out with formal regulations. HRSA, I think, has found that they are limited in their current authority to do many of the things that they wanted to do. So, for example, in 2010, they put out guidance that allowed covered entities for the first time to have arrangements with multiple contract pharmacies. Contract pharmacies are pharmacies that are not part of the covered entity. So this could be everything from a large pharmacy chain to a small independent pharmacy. So what we saw was 340B many providers started to have multiple arrangements with these contract pharmacies. And then about a decade later, manufacturers started putting restrictions in place. And then many manufacturers ended up suing the federal government. And while one of those cases is still in the federal court system, there are two federal courts that have said that the 340B law, didn't support HRSA requiring manufacturers to provide 340B pricing for multiple contract pharmacies. There are other examples of that. I think that both covered entities and manufacturers, feel like HRSA could do more with the authority it has. But I also think that depending on whether you're a covered entity or a manufacturer, you might like some of those things that they would do with that authority, and you may not like others. And I think one thing I also would just mention here is that even if Congress were to give the agency more regulatory authority, I'm not sure that that would necessarily sort of cause all of this litigation and these disagreements between manufacturers and covered entities would go away, because I do think that covered entities and manufacturers often do have very large, significant fundamental differences in how they view the program. And I think the other thing I would say is that even if Congress sort of redrew the program, it's still going to be up to HRSA to determine what that program looks like, and how they end up implementing the program could create new areas of disagreement between the federal government and stakeholders, and between different groups of stakeholders.
Got it. And Greg, what is the role of these vendors? Like, we know Second Child Solution, they were working on a solution with a beacon, and like covered entities were going to submit claims through beacon, and then Truzo also came into the play, and one of the manufacturer wanted to go with the Truzo. So what is their role? Like how they are collaborating and creating a trust factor between manufacturer and covered entities?
I think of Calderos and Second Sight Solutions primarily as technology companies, and that manufacturers contract with them and they set up portals through which covered entities can submit 340B claims data, and those companies have sort of back-end processes that they use, taking that data from the covered entities and kind of running against the data that they get from the manufacturers to, either, detect if a 340B duplicate discount happened, or to prevent a 340B duplicate discount from happening in the first place. So even though a rebate program would be new to 340B, covered entities do have some experience with these platforms, because when manufacturers started putting those restrictions in place around contract pharmacy, what they did is they said, well, if you submit 340B claims data to us, we will provide you some level of access to contract pharmacy. And so what we're looking at now is manufacturers sort of, building off that experience with those platforms, and then looking to sort of use some of that same technology or similar technology to run 340B as a rebate program, again, if HRSA decides to go that direction.
Got it. And Greg, it seems like you have quite well experience all around these areas. So if you could design an ideal data governance and compliance framework for 340B, what principle would need to be at the core of it, and who would need to be involved to make it workable?
Since we're focusing on duplicate discounts a lot, I think a solution that a lot of covered entities, not all, but I think that a lot of covered entities would like to see, and I think some manufacturers as well, would be what has sort of commonly become known in the 340B space as a neutral 340B clearinghouse. And this would not be a clearinghouse run by covered entities or run by manufacturers or run by a technology vendor that contracts with manufacturers. It would be a system set up by the federal government or a conflict-free federal government contractor that would take data from 340B covered entities and then sort of run it against medical data to determine if a 340B discount was used, and then that information could be used to determine if a manufacturer owes a Medicaid rebate or other kinds of federally required rebates that manufacturers have to pay, but again are protected from duplicate discounts. I think that it would provide manufacturers with maybe a greater assurance that Medicaid duplicate discounts are being prevented. But I think what it would potentially give covered entities that a lot of covered entities like is that they wouldn't be potentially submitting data to a bunch of different manufacturers that have their own policy. It would be a single clearinghouse that is operating under one policy. I think also, too, one thing that you might have with a clearinghouse that I think does kind of work with maybe some of these platforms that manufacturers have come up with is that it would allow the claims data to be submitted retrospectively. It wouldn't have to be based on modifiers applied to claims, which we have seen with some state Medicaid programs and Medicaid managed care agencies. And I have spoken with some manufacturers over the year that I think have expressed some support for the idea. I'm not exactly sure about the level of support. I think many manufacturers probably would still prefer a rebate program, but I think that given how strongly the covered entity community as a whole is opposed to a rebate program, a clearinghouse might be that idea that sort of balances the competing interest of providers and manufacturers.
Got it, Greg. And Greg, what are your views about AI? It seems like there are a lot of complexities in this program. Do you think AI can help us to streamline this process at any stage and make it easier, especially for the providers and covered entities?
Yeah, obviously we're in this amazing time of AI. You can't turn anywhere and not hear something about AI. And that includes, in the 340B space. I do think that AI is already being used by manufacturers and covered entities. I think for manufacturers, again, I don't work at a manufacturer and I don't primarily work with manufacturers, but I'm sure that they are using it, for example, to really sort of help them identify potential duplicate discounts and really refine their processes to have as much certainty as possible about whether they think a duplicate discount might have occurred. I think that covered entities are using it to manage their operations and compliance. Again, if you can do something that was previously just a manual process, or even if it was digital, it required a lot of labor. If you're able to deploy AI to do that, that then frees up labor to be used elsewhere, either to manage other aspects of the 340B program or potentially even using that labor outside the 340B program. I think much sort of like our global society we live in, I think that 340B will feel a lot of impact. And I think we're only beginning to see what it is from AI.
Got it, right. And then, Greg, like there are concerns about privacy and security as well. Like many manufacturer and also providers don't feel comfortable that data is going to AI, these AI models. And do you have any thoughts on that part?
I do know that while maybe it's not the issue that has gotten the most attention in providers expressing their concerns about a rebate model, I think they are concerned about submitting this data to manufacturers. While this doesn't relate to the rebate model, we've also seen an increasing number of manufacturers requiring covered entities to submit 340B claims data as a condition of receiving 340B pricing. And not just claims data, but we even recently saw a manufacturer ask for encounter data as well. And I think that yes, providers are concerned about the burden and the cost of providing this data and managing all this, but I think they are concerned about the confidentiality of the information. I think they're concerned about how the information is being used. And I think also something I've been hearing a little more about is that these claims have a certain value to the manufacturers. Like they can use all of that data for different things. And instead of having to, I guess, compensate 340B providers for that data, providers are just sort of having to give that data away to continue to get access to what they already get access to, which is 340B.
Got it. And Greg, before we wrap up, we want to do a rapid fire round. So these will be quick yes or no questions. So
Okay.
you don't need to overthink. Just go with your gut, yes or no, okay? Let me know when you're ready.
I'm ready.
All right. Okay, here we go. Is the duplicate discount problem genuinely unsolvable under the current upfront discount model, or is that framing overstated by manufacturer?
Overstated by manufacturers.
Is a shift to rebate-based 340B structure now inevitable, or regardless of what covered entities or HRSA prefer?
No.
Does Medicaid managed care create complexity that makes a workable national compliance standard genuinely difficult to achieve?
Yes.
Is the operational burden of rebate model conversion being underestimated by most of healthcare leaders?
Yes.
Is there genuine common ground between manufacturer and covered entities, or is this a zero-sum policy fight?
Some common ground.
Is the future of 340B more likely to be shaped by lawsuits than HRSA rules or new laws from Congress?
Lawsuits.
Well, that was great. Thank you. And Greg, if people who are listening who want you to connect with you or follow your work or go deeper on any of the ideas or topic that you have, what is the best way to reach out to you?
Yes. The best way to reach out to me would be by email. My email address is greg.doggett@powerslaw.com. So greg.doggett@powerslaw, just like superpowers.com. Feel free to reach out if you have any questions after listening to this podcast, or if you think that my organization might be able to assist you in some way.
Greg, this was genuinely substantive conversation. We really appreciate your time and depth you brought to this topic. And to everyone listening, thank you for joining us on 340 Pulse. See you next time.